There were quite a number of questions about rib fractures, primarily about pain management. So I know Professor De Moya has already answered some of them, but for the benefit of other participants, how would you do the pain management depending on the type of rib fracture that the patient has?
So there's a spectrum of pain
Mhm.
management that goes from systemic pain management to local parameters, rib blocks, to regional blocks, either local regional like serratus anterior blocks to erector spinae blocks to thoracic epidurals. I think that in addition, though, to those parameters, I think there's other non-narcotic types of pain management options that might include anything from non-steroid anti-inflammatories to Tylenol, acetaminophen, quite frankly, to acupuncture for type of control. And so I think that it's important to use a combination of pain management modalities is very important. And obviously, I list a variety of ones because there's such a variety of resources and available to folks. So those are the most commonly used things. I think that there are many studies that suggest that regional blocks, particularly thoracic epidurals, are quite effective. I think that some of the newer literature is looking at regional blocks like serratus anterior blocks, the use of a continuous infusion of local anesthesia into the spaces of the serratus anterior is becoming more popular and more useful. I think that so it's really a combination thereof that's important for pain management. But what's important also is to start early. If you have the capabilities of doing regional blocks or doing thoracic epidural blocks, doing them from the time that they hit the emergency room, as close to that time period as possible is important. So those are my general thoughts about pain management.
Thank you, Dr. Mark. Next question to Dr. Mayur. First of all, thank you very much for making us smiling on this nice morning in the India today. And we have a very couple of interesting questions. The very first question is, what other possibilities as of now you see to be a MacGyver in trauma surgery?
Well, I mean, there's a lot. It's hard to cover that in 20 minutes. I think that the Dr. Concepcion alluded to them, talking about fracture management and stabilization using tubes, using poles, and using sticks. And, talking about MacGyver, it really depends on what your resources are, right? I mentioned Jugaad for a reason, for this audience in particular. We're in the United States, we're blessed to have almost any item we want. Dr. Payana, Dr. Boyer, Dr. Jamoya, you stick your hand out and you ask for whatever device you want and you have it readily available. And I really loved, Juan Carlos's talk about going elsewhere and seeing you don't have the things that you have back home and you're not challenged. So I would offer to you all that you all are the MacGyvers. You are doing it day in and day out with limited resources, and it is we have our own expertise, but we have just as much to learn from you as you have to learn from us. So let me open with that.
Thank you, Dr. Mayur. One possibility or one MacGyver kind of thing we did would like to discuss with you and Dr. Mark, that we recently started refixation program, and Dr. Amit is one of the principal investigator of that project, and we are using the steel wire which we used to use in fixing maxillofacial surgeries, and that we are using for refixation. I think Dr. Amit can make further comment on that.
So basically, it's sort of a MacGyver sort of moment for us, because we are resource crunch in terms of the patients cannot pay for the plates, and the plates are very costly, and the hospital also at times cannot afford the plates, and therefore we wanted to fix the fracture. So we thought that sort of instead of plates, should you use any other thing to stabilize the fractures? And that's when we thought that why not just do it with steel wires like we used to do for median sternotomy. So we're doing that. Let us see what the results will be.
Yeah, it's
You
an
know,
interesting
that
concept.
it's
I mean, Mark, I guess you could definitely chime in. I guess the only question is, chest wall compliance. Something you have to be mindful for. I guess the rib plating each individual rib. So if are you taking one rib and fixing it to another rib? So how are you all doing that?
Yeah, okay. So
Good
we
point.
just bring the fractured ends together, and we would just use a small drill to drill in, and then take this exactly the same steel wire we used to do it for the median sternotomies, and then just sort of twist that, and we do it at multiple levels for multiple ribs.
Got it.
That's what we're doing actually, rather than actually plating them. Any
yeah,
comments on
no,
that, Dr. Mark? Yeah.
yeah. So it's great. The innovations that we see in many different places. You have to use what you have available, and I think that one of the aspects of bone fracture repairs, there are two major components that I think are important for whatever type of devices that you're using. One is being able to reduce the fracture. So if you're able to reduce the fracture and align the ends of the fracture, and then immobilize that fracture with some compression, ideally, as much as possible. Now, there's a spectrum of fixation that different modalities allow you. So, for instance, in my work in Cuba, they use a technique where they actually take a external fixator, almost like a K-wire type of rod, and then actually they under local anesthesia tunnel it on top of the rib cage over a segment of it, almost like a external fixator, and then they remove the pin under local anesthesia, just like they would do an external fixator, a fixation device on the leg or the arm. So doing a wire, obviously you can bring the bones together, but there's still some mobility there because it's a little bit of a joint almost. But it's better than leaving it very, very overridden. So I think that it should be used. I've also used, when I was starting to use it, I didn't use these fancy rib fixation devices nowadays, but more stainless steel plates that were used for other kinds of bones. They're a little thicker, but honestly, they work just as well if you had access to that. But so there's a spectrum there, and I think that it's great that you're using that. I think that it's important, and it can still provide some structural support to the chest wall.
Thank you. Esther, any other questions there? Yeah.
Thank you. Professor Kim has a question for Professor Puyana. So may I call Professor Kim? Can you unmute yourself?
Thank you. Thank you for giving me an
Good.
opportunity to ask.
Mhm.
Dr. Priyana, I am very interested in also to global surgery, and so I try to perform any kinds of global surgery in the African country right now. So I'm very worried about before the performance of any kind of activities. We have to know the current and local circumstance, especially in medical activities by local medical personnel. like the surgeon. For example, now I want to know the laparoscopic surgery activity of the performance in some kind of African country, but I don't know how to access the information. It was not easy for me, and so one of the people like that. So please give us some tip or some good way to know about the current and then local people's local medical personnel's activities and opinions, their opinions and their current activities. It is my question. Yeah, thank you.
Uh, Global surgery is a complex subject that has many, many angles, and people look at it from very different perspectives. My advice is that if you in Korea want to participate in a collaborative interaction with a place where you can create innovation and partnership, you need to do it on a personal basis. It's better to have someone with whom you connect and began to learn what the local needs are and understand the cultural aspects and the local context. That is critical to begin a long-lasting, sustainable collaboration. The Lancet Commission is a way of looking at the global health from a 20,000 feet view about how you getting engaged, the ministries of health, and how you develop surgery anesthesia plans for the whole country. That is very ambitious, and although some African countries have begun to do that, it is easier to do it in a small scale. It happens that I am from Colombia, so I started there with my classmates from medical school, and that's how we started our first interaction, because I knew them. And then you began to sort of advance and create new opportunities. And I think that acute care surgery and trauma are perhaps the two disciplines that best allow to develop global surgery perspectives. So you were talking about the MacGyver. Well, people use mosquito nets to repair hernia meshes. So I'm not just talking about trauma. Dr. Fitzgerald in Duke has worked in Uganda, and she has created a factory in Uganda where they actually develop a prosthesis for gastroschisis, 1,000 times cheaper than whatever you can get in the United States. This woman is a surgeon from Duke who is also a biomedical engineer, and she has created enterprise in Uganda, developing these new materials that are cheaper and fabricated there locally to treat pediatric surgery problems. So the horizon is huge, and the more we travel, the more we connect, the more opportunities will surface.
Thank you. In terms of collaboration, and I tried to join the Lancet Commission of global surgery, and I have some experience in Bolivia, in local hospital who built by Korean government, and I joined to the teaching the critical care and the trauma surgery at the local medical doctors, and at the time I have some experience. I have to get the information before the some performance. Okay, thank you. I'm very appreciative for your advice. Thank you very much.
Thank
For
you.
Professor Boyer, we were actually smiling here. We're saying we actually MacGyver our simulators. We've been doing that ever since. And simulators can be expensive if you're going to buy the commercial ones. But there's a question here from the chat box. How skillful can a trainee be after training with artificial or augmented reality? So it's a question of how can you certify someone if it's only worked on a model and not on a real person?
So I think that's something that's under investigation. We're looking very carefully at that, is how to best utilize tools such as augmented reality and virtual reality. And I think at the end of the day, these will be tools that will augment the training that we do. I think the real value of this will be in terms of improving the learning curve. So, for instance, traditionally we train by bringing people into the animal lab and having them perform procedures on an animal. It's very costly. And if someone has to learn in the lab, you've wasted that resource. And so by allowing people to practice skills in an augmented or virtual reality setting, they can actually they can come to a course or come to a test and be ready to perform on that test. I think the other real advantage and potential of these virtual reality and augmented reality is the ability to refresh skills. So someone has been trained to do something, but they haven't done it for 5 or 6 years, or maybe never have practiced it, such as many of the trauma skills that we need to know how to do on patients, but are rarely called upon to do. And the ability to telementor someone or have them have a virtual mentor, I think is a real powerful tool. Thank you.
Thank you.
I
Thank you,
think
Dr.
Dr.
Mark.
Boyer, yeah, I just had a comment on Dr. Boyer's presentation. I did my simulation fellowship in the US, University of South Florida, I played with the high fidelity simulators and other things. So no doubt, cost is there, and I'm sure from Dr. Boyer's lecture, we all came to know that the cost actually can be cut by the virtual reality, because infrastructure has a cost. Mannequins have a cost. The items which are cut and have to be replaced are consumables, and therefore they have a cost. And I'm sure that electronic platforms like VR and augmented reality cuts all those costs. So if you see in a longer term, these technologies will definitely be more cost efficient or cost effective than the actual simulation labs. I just had one question for Dr. Boyer. What about the haptic feedback, which Dr. Kim also, touched upon? Are we coming, to terms with some simulators having haptic feedback, especially the VR ones? Is this going to be a reality in terms of the future simulators?
Yeah, I think we're not quite there yet, but I think it certainly is on the horizon, and there are some initial forays into that particular topic. For instance, the new Apple iPad, the tablet, actually has pencil-enabled haptics, and I'm actually working with a small company right now we're working on a augmented reality training device to teach people how to do some surgical procedures. And it's not perfect, but you can actually use the pencil and create various instruments, representation of a scalpel. You can actually feel some haptic feedback when you're using the instrument. It's not perfect, and certainly the simulators that we use and using the instrumentation on it, they're not human tissue. Their quality, they're not like human tissue, most of them. And so, I think what you're doing is not necessarily teaching someone the exact tissue planes and the tissue, but the steps of the procedure. And I think that the simulation has a great deal of usefulness in that regard.
Thank you. Thank you, Dr. Mark, for your expert comment. Now, one question for Dr. Mayur. Sir, as you know that besides COVID-19, one more pandemic the whole world is going through is, kind of increasing healthcare professional getting, day by day beaten by the relatives, kind of thing, you can say. So what you see that the MacGyver our inventions, which are not being supported by research or by any society or not recommended by an expert, if we are using that in our day-to-day life, how see them in a legal intricacies around the world?
That's a very tough question, to ask. And I will leave you with that last slide that I showed you. I think that anytime you create something, right, although the basic assumption is that we're trying to do good, I think it does need to go through a vigorous process of study to make sure that you are not inadvertently harming somebody. The basic premise is first do no harm, right? So things that you use that you think may be of benefit. I think it's important to be creative. I think it's important. One of my professors, Clay Christensen, would talk about disruptive innovation. I think it's important to do that, but I think that there's no substitute for then making sure that once you've implemented or utilized those things, Dinesh, that they have to go under through vigorous scientific, evaluation before it goes mainstream, because there are going to be legalities, and depending on which locale you're in for using them mainstream. I'd be happy to hear what my other colleagues think, but I think that's imperative that you do that.
Amit, your comment on this?
No, I think Mayur is very much right when he says that all innovations. I mean, for a quick fix, for a single case, maybe, and if you succeed, it's fine, like stopping hemorrhage and things like that. But if you want to create a pattern, if you want to create a device, then it's not that you have to go through the rigors of research. You have to go through the rigors of testing it. As you said, do fair bit of sort of due diligence on the research part, and only then probably introduce it as an acceptable innovation rather than just sort of a jugaad. With that, I would ask Esther if there are any pressing questions. Maybe one question, because we are surpassing the time, and
We
then
have run
probably
off.
we'll close on it.
All our
Yeah.
questions have been answered in the chat box too. So I think we're good. Thank you so much to all our speakers.